we get going?
Yeah, mine's good.
Okay, so welcome everybody. This is the voice of Paul Gross. I'm the President and CEO of the Cerebral Palsy Research Network. We're going to run this a bit as an orientation sort of first meeting. We used to do these meetings with some regularity a ways back, but we've been a long time going without a Shannon on board, and we now have Shannon Schlater, who's our data coordinator. So we've got a way to coordinate these meetings, and I know a lot of you have reached out to me over time for answers to questions that I'm hoping that Shannon will be the sort of focal point of that, and we'll determine a reasonable pace for this. But I'm gonna give you kind of a whole network overview. I thought we'd start by just doing introductions, and I'll just so I'll say I am an adjunct professor at an adjunct associate professor at the University of Utah. I live in Seattle. I have a 16-year-old boy who has cerebral palsy and hydrocephalus. He just went through a 6-hour major orthopedic surgery 2 months ago. We just flew home from the East Coast after 2 months there doing post-surgery and post-surgery intensive rehab. And this is my third clinical research network that I've founded and or co-founded, and first one that I've ever run. So let me hand it. I guess I'll call people out for introductions. So Shannon, you want to introduce yourself?
Yeah, so I'm Shannon. I'll be the data coordinator. Like as Paul said, I'll be a nice point of contact for you guys, any questions or problems you guys have. I just came from Huntsman Cancer Institute, so in Salt Lake City as well. Also working as a data coordinator. So I'm really excited to be working here and with Paul and CPRN.
Great, thanks. And I'm going to call you guys out as I see you on my Zoom. So next up is Jackie.
Hi, I'm Jackie. I'm the research specialist on the CP team here in Boston.
Okay. Lynette.
Hi, I'm Lynette. I'm the clinical research coordinator for pediatric neurosurgery here at Primary Children's Hospital in Salt Lake City. Dr. Robert Bolo is the PI on the CPRN.
And you've been involved for, it's probably four years or so?
Like 3.
Yeah, 3
Feels
years.
like
Okay.
30.
Yeah. Thank you. Michael, can you turn on your camera for a minute and say hello?
Oh, hey, my camera was pimping, but yeah, I'm not in the office right now.
Totally fine.
Yeah, I was just, I'm here at University of Oklahoma Health Science Center. I'm working with the neurosurgery department, and I'm just a clinical research coordinator. So nice to meet you all.
Newest member of the team. Great. Welcome, Michael. Thanks. Mariah.
Hi, everyone. My name is Mariah. I'm the clinical research coordinator for Riley Children's Hospital, pediatric neurosurgery here in Indianapolis. And Dr. Jeffrey Raskin is our local PI here.
Great. Thanks. Katie.
Hi, everyone. My name is Katie. I'm a clinical research assistant on the CP team at Boston Children's. Nice to meet you all.
Thanks. Sachin.
Hi, I'm the other research coordinator here at Boston Children's. I've been working on CPRN for the past year now. Our PI is Dr. Shore.
Great. Thank you. Deborah.
Hi, I'm Deborah. I am the clinical research coordinator at Seattle Children's Research Institute. I just came into CPRN in March, but I've been coordinating a couple of other registries for Seattle Children's for the last 2 years. So glad to be a part of this with Christy Bjornson as our PI.
Great, thanks. Kirsten.
Hi, everyone. I'm Kirsten. I'm the clinical research coordinator at the Weinberg Family CP Center here at Columbia in New York City.
Thank you. Anastasia.
Yes. Hi, everyone. So I'm Anastasia Smith. I am the clinical research manager in the Children's of Alabama, or UAB. We've been part of CPRN from the very beginning, mostly focused on the surgical part of the registry. And Dr. Rock is my PI.
Thanks. Dante.
Let me turn my camera on.
Okay.
I think. How do I do that? Okay. Okay, sorry. Hi, I'm Dante. I am the clinical research coordinator at Children's Mercy Hospital in Kansas City, and our PI is Dr. Partington. And I don't know how long he's actually been a part of the CPRN network, but I know I've been on the study for a little over a year, maybe a year and a half or so.
Yeah, he was on originally at Gillette and then started it at Children's Mercy, and it's been a couple of years now. I think it's been 3 years, so took a little time to get up and running. Okay, I can't remember who's on by phone at the 952 number.
That's me. Hi, everyone. This is Jen Carpenter. I am from Gillette Children's Hospital in St. Paul, Minnesota. Dr. Novacek is my PI here. Dante, please say hi to Dr. Partington for me. I've been on CPRN since Dr. Partington started it up here. Oh goodness, five or 6 years ago. And so I've worked on this project for a long time now. Gillette is working towards getting some automatic data transfer set up with our Cerner system. So I am deep in this project regularly right now in coordination with our IS team.
Yeah, in many ways similar to Kirsten, who's dealing with the Epic forms, although you guys are creating forms from the beginning. So, but Kirsten could be a resource for you in many regards in that regard. Abby, I know you did a short one, but Abby, you want to reintroduce yourself?
Yeah, hi again, everyone. My name is Abby. I'm located here at Rady Children's, San Diego, and my PI is Dr. Deval here at Physical Medicine and Rehab Department. Nice to meet you all.
Great. Well, thanks, everybody. All right, I'm going to use some slides to take you through the network. And, you know, for some of you that have been involved from the beginning, some of it will be repetitive. There is a fair amount of new information here that might be useful. So I would encourage you to sort of tune in and tune out when you see the sign go, yeah, I know all that. You can feel free to tune out, but stay tuned in. You may learn some things. Okay, so I'm going to take you through a little bit of the history and the founding of the organization, what our mission is, the organization, like as in an org chart, because we're actually quite big, and sort of what is involved in the network. And then we're going to talk about the registry and then our research and quality improvement projects. So the network was founded out of an NIH workshop back in late 2014. It was the first NIH workshop on cerebral palsy, entitled State of the Science and Treatment in Cerebral Palsy. It was pretty clinically focused. There was a little bit of basic science focus, but there was a planned basic and translational meeting the following year. So it didn't focus much on that. And it, unlike many NIH meetings, at the end, the people running the meeting stood up and said, so we've heard these topics and we want to get a task force going. And so we actually created 5 task forces out of that group. And these were the 5 topics. One was to start a national CP registry in a country where we don't have socialized medicine and don't have a way of seeing all patients. The second was to do more comparative effectiveness research. Third was to study the population that was the biggest but the least studied, which was the study of adults. The fourth was to make sure we had a sort of a mentoring setup that would bring young clinician scientists into the field. And then lastly was to advance basic and translational science, though there was a plan for a follow-on meeting that happened actually in 2016. So when we were founded, we started as a group of people that I was co-leading with Deb Gabler out of the Shirley Ryan Ability Lab in Chicago to start a national CP registry. And we had 2 groups, one working on a population registry and the other looking at a sort of center-based, intervention-based registry. And that ended up turning into CPRN, but we really sort of wrapped our arms around these first 4 topics and sort of built the organization to do that. But over time, for a variety of reasons, we've ended up doing all 5, although on the basic and translational, it's a central piece because we're doing a lot of work in genetics, but it's not like we are funding and doing lots of basic and translational work. it was really, the network was really a merger of two core experiences that the founding team had, and that was the Hydrocephalus Clinical Research Network, of which at least one of the coordinators on the call on stage is very familiar with and has been involved with for a very long time. And that's at this stage, that's a 15-year-old clinical research network with 14 centers, and has really transformed neurosurgery and not transformed clinical research in neurosurgery, especially in pediatrics, but there's an adult network as well. And so that really drove a lot of the experience because I co-founded that network. And then there was a doctor named Dr. Gary Noritz, who was at Nationwide. And Nationwide's experience was they had built a single center registry, but they had built it into their EMR. So they collected data as a function of usual care. So they would do standard care. That data would be captured as discrete data. And that was really a fundamental change from the way HCRN had worked, and was kind of a bit of a North Star for us. And we've been patient-centered from the outset. So we're not just a set of clinicians that are focused on research questions that are most pressing to them, but really involve the community at every step of the way. And I'll talk a little bit more about that. But the fact that my experience was so deep in the Hydrocephalus Clinical Research Network, which is a neurosurgery only network, is why you'll see that a lot of the coordinators here are part of a neurosurgical team and have that focus. So some of the key milestones for us is we launched our clinical registry in March 2016, and it currently has more than 5,000 patients. The registry elements are taken by Epic. So our database definition is actually in Epic, that the most popular EMR. And then, as you heard a little discussion, the folks at Gillette are building that same data capability into Cerner. And hopefully that is going to go into test in the coming months, and then eventually get rolled out to the other Cerner sites that are in the network. So today we have 18 sites that are actively collecting data on CP patients, and some are collecting it just on neurosurgery patients, or some are collecting on just patients that come through PM&R, and some are collecting it on their whole population. So Seattle's an example of that, and I'll talk a bit about that. As I said, we're patient-centered from the beginning. One of the first things we did was we went out and got funding through PCORI to do a patient-centered research agenda, which we conducted a whole process in 2017 and published it in 2018. And this came up with a sort of a top 16 research areas, and that's really driven our research agenda. We've had some significant public funding milestones that support, they're not registry grants, but they support the registry infrastructure. So we got one from the Pediatric Epilepsy Research Foundation, and that allowed us to add support for looking at the crossover between CP and epilepsy, where there's a very high co-occurrence of those conditions. And we also got an NIH grant through the University of Arizona, which got a $3 million grant to study genetics in CP in 2019. We launched a patient-powered registry. We call it the Community Registry in March of 2019, and this is a way to collect data that is not clinical data, so learning about people's lived experience in the community. We have over 1,000 participants split between caregivers, typically most often caregivers of kids, and then adults with CP. And that is a cross-sectional registry, and it's longitudinal. So we're doing a study of adults as one of our core studies, and we've got over 200 patients enrolled in that, and we follow them every year, trying to keep track of changes in their life. We have 4 quality improvement initiatives that we've launched across the network in 2020. And so that's a big focus that we've added and is key to our strategic plan over the coming 5 years. And those are in hip surveillance, dystonia diagnosis, care of adults, and then our longest standing one, which is intrathecal baclofen pump infections. We've had 4 publications, we've had over 20 academic presentations, and we've got 8 manuscripts in the hopper, so we're a little bit behind on publications. Let me pause there and just see if anybody has any questions about any of that. Okay, gave sufficient time for unmuting, no questions, moving on. So a big milestone for us was in January 2021, we merged with what's called CP Now. And CP Now was a nonprofit that was focused mostly on education, a little bit on well-being, and on funding research. The founder of that organization had been very involved with us since that NIH meeting, and actually coordinated our community engagement. So that's Michelle Schusterman, a name you'll hear a lot. And so what we worked on post that merger, that gave not-for-profit status to CPRN. Before, it was just done as sort of a loose collaboration. And what we've worked on since then is the integration of all of our work, and I'll talk a little bit more about that. So the mission of that organization is to optimize the lifelong health and wellness of people with cerebral palsy through high quality research, through educational programs, and through community programming, which really largely means well-being programs. So that's sort of an expansion of the CPRN mission. Okay, so the network is now a 501c3. Before, it was organized more like the Hydrocephalus Clinical Research Network was organized, which is really a group of clinicians and hospitals just agreeing to collaborate. What we have in common is we have a data center that's based at the University of Utah. Those are actually different departments and are not the same people that are doing the data coordinating between HCRN and CPRN. So it's a sort of a different approach to handling a registry. And so some people like Lynette, I don't know if you get experience with that, but I certainly know that Anastasia has experience with the differences, both good and bad, of those different approaches. So we have at our core this clinical registry and this community registry, and then we've added education and well-being programs from our merger with CP Now. So this is just to give you a sense of, what, now that this is a merged organization, what all the sort of big boxes are. So we're actually technically still CP Now, but we're doing business as the CP Research Network. And that's really just how a tax entity is implemented. I'm sure you've heard of some business doing business as, and that's how we're doing business now. We have a group of clinicians that form a steering committee that help plan our research and quality. And we have a group of advisors from the community that are a mix of adults with CP and caregivers of people with kids with CP predominantly, and some caregivers of adults. So we really have sort of 3 big boxes. We have the network, which are all the sites, all of you as coordinators, how the site's organized, and I'll talk a little bit about that around study groups, subcommittees that do things like approve manuscripts or approve new scientific projects, and then our QI focus which has really been grown in the last year, where Dr. Amy Bales is our sort of core coach for that. We have the Data Coordinating Center at the University of Utah, which is headed by Jacob Keene, who's a rehabilitation researcher, happens to have just gone on sabbatical in July, right after hiring Shannon. So the boss kind of came on board, and then I brought her on board and then dashed, but he's got a right-hand person in Anne-Marie Drennan, who does project management and research management, that is sort of helping the trains run on time while Jacob is on sabbatical and he remains engaged. And so I've got a little bit of a mix of functions and results in this set of boxes. So we have data management, which includes Shannon and Lema Al-Warkawi, who does our sort of business intelligence on our data. We have a statistical core. We have programming, which is largely done by Blair Cooper, that touches a lot of different things. And then the core sort of infrastructure as a result of this is we have the registries and we have a set of tools. So we have an iConsent tool, which is being used by the genetics study. We have a registry explorer tool, which is used by researchers to sort of look at which data elements have content in them in the registry to help plan studies. And then the third box is operations. And this is really where the entity is sort of running the other programs. So we've got people doing fundraising, people running our education and wellness program. We've got someone running our finance operations and someone doing sort of blog posts and social media and things like that. So again, there's a lot of information. Let me pause and see if people look at this and say, you know, where does this live, or have any particular questions about anything I've said so far. Okay, gave it the 5 seconds for no unmuting. Going to move on. Okay, so just to give you a little bit of idea of the data in the registries. So this is from back when we had just about 4,500 patients. So GMFCS, which you all either, if you're not familiar with, you will become familiar with. This is one of the critical data points on a person with CP, gross motor function classification system, and it's a 1 through 5 rating with Roman numerals, and you can sort of see the distribution of GMFCS. So 4s and 5s are wheelchair users. 1 through 3 are independent ambulators, although 3s use assistive devices. And this is such a critical data point for planning studies and understanding who is in our registry. So this is just one critical data point. And then on the other side, you just see the pie chart of who we have in the community registry. So our registry is open to advocates and providers. I'm sorry, not our registry, our portal is open to them. But the registry is just either people or caregivers. And this is an older data point. We have over 1,000 at this stage. Okay, so the network is spread across North America, although we currently only have one Canadian site and it's not quite up and running yet. The green pins are sites that are collecting data. The yellow ones are, actually I got to change that Jacksonville one. They're now enrolling patients. The yellow ones are preparing the registry. And for the sites that are not using REDCap, there's a fair amount of work, as I'm sure Abby could talk about, or Kirsten could talk about, for UCSD or for Columbia, to get the forms up and running, to get the clinicians using the forms or changing the forms so they're useful to them, and get that up and running. But then again, a number of these sites are also REDCap sites. The red ones are still doing like the BAA or some other agreement, and the blue pins are sites that are actually have expressed an interest, and they're somewhere in the process of basically getting to submitting their IRB and getting invited to join the network. Okay, I'll pause again before I think I'm about to change topics. Okay, so our study pipeline, we're here to sort of be a facilitator of research. The left-hand side is the funnel where new ideas are discussed and then go through an approval process, and then they move through and apply for funding or internal support, and then they move through to implementation, execution, manuscripts, and publication. The green ones are the ones circled in green. I can't remember why I circled them in green, so I'll have to remember that for future reference. Can't remember that. Anyway, moving right along. So this gives you an idea of like the level of activity going on in the network is quite broad. And the orange ones are our current QI projects, although our transition QI is kind of on hold at this stage. Okay, so the way the network functions is the PIs have biweekly meetings and an annual 2-day meeting. You guys are all invited to those meetings. They may or may not be useful to you. You should all be copied on them. Sometimes the CRAs are there in lieu of the PIs because they're during the day, and very often the PIs are in clinic or in surgery. So we record all of those. We do meeting notes for all of those, and all that content is available on Teams or YouTube. The weekly meetings, we approve new concepts is one of the core things we do. We share models of care, sort of best practices, and then we cover sort of news and status and key things that just need to happen. They're important for the PIs to know. And then annually, we get together to sort of advance the studies further, to get people more sort of knowledgeable about them, advance the infrastructure of the network, and to sort of quite literally network. So the unit of work is really a study group for researcher quality improvement. And those meet either monthly or in some cases bi-weekly. They're organized by the PIs and the co-PIs, and they're open to pretty much so anyone in the network. It's a lot of this work is based on individual PIs' interest and focus. The sites work directly with the data coordinating center through Shannon, through Lemma, or through Jacob. If they're working on, Jacob is very often the co-PI on multi-center grants. Sometimes it's me. We work with you and your Epic analysts, if you're an Epic site, to sort of customize forms and notes. We work with you as a CRA to help be available with answering questions about data collection. And then more recently, we've established QI teams, which are intended to have a sort of a very local presence for data gathering and for data quality. And we're using more than the registry for collecting that data. And then lastly, there are standing committees that the PIs are on. There are these review committees, there are ad hoc task forces for defining the registry, things like that. Let me pause there before I go into a few more comments about the registry and then open it to sort of questions and discussion. Any questions about how we function or how you should plug in? Okay, moving along. So the clinical registry is designed to capture, the design point is really to gather that data out of clinical care. So it's a little bit different than a registry that's designed to answer a specific question, and therefore it gathers a lot of data elements, but there are very few actual required fields. So the whole idea is to take what people would write into a note and capture elements as a discrete data point in the same shape every time it's captured. So GMFCS should be captured the same way every time it's captured. And this gives us this apples to apples that allows us to do more work with it. But it is really intended to support practice variation. And that's why we have very few required fields. And we also impose very little, not sure the right word, but as an example for spasticity, there are 3 scales for spasticity. There's the Ashworth, the modified Ashworth, and the Tardieu. And we support whichever of those and the data collection for whichever of those that the physician wants to use. We may change this in the future, but that is sort of the design point. It's meant to support clinicians, medical doctors, as well as surgeons, particularly orthopedic surgeons and neurosurgeons. In the non-surgical area, we've got developmental pediatrics or internal medicine for adults, neurology, typically movement disorders, neurologists or epileptologists, and then physical medicine and rehabilitation docs. And then on the surgical side, we're supporting neurosurgery, The neurosurgeons have 2 surgeries that they do for kids with CP. There's a third, but there's intrathecal baclofen pumps and selective dorsal rhizotomy. Some do DBS, deep brain stimulation, but that's just less common, and we don't capture any of that in the registry at this stage. And then the orthopedists have this huge armamentarium of surgeries that they do, including Botox injections, which are also very often done by the physical medicine docs. And then we capture physical therapy. We're not currently doing occupational therapy or speech. The data is intended to be captured prospectively and longitudinally. So, clearly with doing chart abstraction, it is not sort of instantaneous. There can be a bit of a retrospective view, but it's intended to capture all the data from the point of IRB approval going forward, and then with every return visit or every return surgery. And so the registry is intended to support practice variation and looking at practice variation, hypothesis generation, some of our quality improvement efforts, and then to do planning for study enrollment. So let me pause there. I've got a couple more slides, but let me see if that's sort of the meatiest side about the core work that a CRA is working on, see if there are questions about that. Okie dokie. So in terms of REDCap data collection, it is intended as an interim step until your organization gets to EMR-based data capture. But in some cases, that's going to be, it'll have been, 5-6 years of collecting data through REDCap before that's ready. So like Seattle is an example of an organization that's been doing whole population chart abstraction into REDCap, but plans to move to Epic in the, they've moved to Epic as an organization. They're starting to look at the implementation of the forms. And so sometime in the next year or so, hopefully they'll shift to using forms as their mechanism. And then the role of CRAs will change. It will take some time to sort out what that means. So because we're intended to focus on the EMR, where the extraction from the EMR is all done through programming, there's actually very little prescription for, do we capture the data at 12 months or 15 months or whatnot. For the EMR, we get all of the data for all of the encounters for all of the kids with a diagnosis of CP, assuming that the IRB protocol is set up to be a waiver of consent, which not all sites are, but most sites are. So I've had questions like, I think some of the folks from Boston were asking, if we have a kid coming back at 6 months and at 12 months, do you want the 6-month visit? And my answer has been, it's really up to you about the amount of resource you have to apply to this. We'll take all the information we can get, but what we've done is we've set up an event grid in REDCap to support, initial enrollment and then annual visit. There are some pre-op follow-up, pre and post-op follow-ups that are not on that annual path, but it's because we're kind of creating something that'll map to EMR data. So REDCap is really a subset of the data that we capture. It's what we call CPRN custom events. So something like a spasticity measurement is a custom observation. It says custom events, but it should really say custom observations. Whereas something like vitals or lab work, we have a form for vitals, but what we expect is that we'll actually get those from the EMR. We'll get demographics from the EMR, yet we have a demographics form for REDCap because that's the only way to sort of make sure we have that data. But there's a lot of data that we don't get. Like we get pharmacy data from sites that are Epic sites. So for a patient that's got a CP diagnosis, we get all of their pharmacy, and that allows us to do things like look at their Botox, their botulinum toxin injections. We get procedure databases. We we get a lot of things just kind of automatically, and we don't try to get REDCap to capture all of that, only the sort of core of what we need. So the subject populations are either very broad, like anyone with a diagnosis of cerebral palsy, but we have a lot of sites that they have like their lead clinician is a neurosurgeon or an orthopedic surgeon, and that's their area of interest. And so they're only capturing the kids that come into their clinic and are getting their surgeries. So the sites that are doing neurosurgery, they're not capturing the kids that come into spasticity clinic that don't go on to get a surgery. They're only capturing the baseline information for them and the surgical intervention information if the kids go and get the surgery. So it's a certain slice, which enables a certain kind of study, but is not sort of population-based. The anticipated effort is basically about an hour to do all the enrollment forms per patient if you're doing just like looking at just sort of digging through and finding patients that have a CP diagnosis and seeing a number of different providers. And then annual visits are estimated to be at about 20 minutes per patient to do an update. Deborah, those are both from Neil, who is 3 CRAs ago on your side in Seattle. You can feel free to, anybody can feel free to update me on that if their experience is different, but that's where that data point comes from. So let me pause there. I've got some stuff on communication and training and see if people have questions, because we've now sort of covered the core of what many of you do.
Hi, Paul. I had a quick question.
Sure.
So we realized that two of our physicians, two PM&R physicians, we don't have surgeon IDs for or codes for. Who should we come to for that? And I've never had to deal with this, so
sure.
I was just handed some codes, but
yeah, sure.
Yeah.
So in general for that, so all things for you guys should go through Shannon, and Shannon will find like you guys have been coming to me for that, and it's fine to come to me, but at this stage, Shannon is really your point person, and Shannon will either hit up the spreadsheet where we've got all the surgeon codes, we add people, or the clinician codes, we add people all the time. She'll go to Blair, who has a thing that generates those, generate that and come back to you with that so you can have that. So yeah. Put in a request to Shannon for that.
Awesome. Sounds good.
Great.
I'll send her Thank you.
Other questions on this? And I'm going to talk about the training materials and things on the next slide and some of the other communications. But
I also had a question. So our site is currently enrolling patients with etiology of the CP. So we're currently excluding genetic etiologies of CP. Right. Is that still the case, like in terms of the subject population they were talking about?
So that is, you can choose to do that, and I do believe you're a consent site, right? Are you informed consent?
Yes.
Yeah. So the network is studying, like the inclusion criteria for the registry includes genetic etiologies. There are a few etiologies that are progressive that are excluded, and I'm trying to think of where the exclusion list sits so that everybody can see that. But maybe somebody on the call knows where that is, but Shannon, that is something we need to make sure people see. But yeah, genetic etiologies are included, but not progressive, like HSP. So I'm not going to remember what HS. It's a spastic paraplegia. I can't remember what the H stands for, but that's not included because that's a progressive disorder, and CP is a static disorder. But the genetics are being included. It's if you guys don't want to include it, that's okay. But we would welcome your inclusion of that.
All right. Thank you so much.
Yep. Other questions? Okay, feel free to come back and ask that. So the way we communicate with people and try to get people up to speed is, so we use a Google group as basically a mailing distribution list, and that allows us to set a calendar invite and have it go out to everyone. And that allows us to just easily reach everyone. Mailing to CPRN CRA, if you have a question, is a great way to get a question answered by a colleague. CPRN investigators is huge, and it's got all of the clinicians on it. And it's not only the clinician, but it's the alternate PI. And in many cases, it's another interested clinician from a given site. So there's probably over 100 people on CPRN investigators. So I would not mail that unless it's an appropriate, question for all investigators. Then we have the CPRN Commons, which is based on Microsoft Teams. And I'm going to spend a moment to sort of take a look at that and make sure you know where the resources are there. If your site is a Teams user, it's a little bit different how you use it than if you're not a Teams user in terms of how you can switch between your site's Teams account and your CPRN Teams account. And then each of those, so we have a CRA channel, we have a channel for each of the QI projects, and within that we've got the training guides and video guides. So I'm going to go and switch to a Teams for a moment and stop this share and share. Okay, so this is my Teams view, which isn't exactly your Teams view, but you can see in the upper right, I've got other teams that I can access there. So if you have your site is a team site, you can do that. I very often like to access the Utah teams because it's kind of got some exclusive aspects to it. I actually sign into it with Firefox and use the web browser interface as opposed to the application. But so CPNow is the entity where we're doing sort of all the marketing and social media. But here's the CPRN Commons and the list of channels that we have. So, if you're working with a group that's working on ITB pump infections, the groups generally don't use the posting and the channel communications very much. They use the email distribution list. But the files as a shared file system are heavily shared, and there are meeting notes here and different things that have been done throughout the course. The effort, we're working on a manuscript. There's also typically a wiki page. So in this case, this is the pump one. Let me go to the one for CRA, so research assistants. There are no posts, but so there's some files. So there's the REDCap training video. There's the training guide. The wiki has information about all of you. I'm sure there's some things that are out of date, and I can see there are places where I don't have emails. But if you ever want to, these are the emails that are on the links for all of these folks. You should feel free. You've got the ability to edit this. So like I'll say, Deborah, you could go in, remove Varen and put yourself in the right place alphabetically, please. And that would be marvelous. So you all have access to this once you've, received your invitation. You can go and just go to this, and I do believe everybody has edit rights for this page. The other thing you could do is go to general, and we have a contacts list, and you could go and see if your contact is in here, which it's very likely not. And you could add a new item and add your contact info. But this is where you can also find all the PIs, some of the CRAs. I don't do, Shannon, we can talk about how to get this most up to date, but I like people to update it themselves so it's a little more self-service. So those are some resources that are good to know about. So like people that are participating in the genetics study, we've got all the files related to the genetics study here. We organize some other teams as separate teams if it's a smaller group. And if we ever need a team of people that are working cross-organization, but we don't want it to be open. All these channels are open to everyone. We create a new team so people can work together, not under everyone's watchful eye. But so if you go to general files, as an example, You've got all the meeting minutes are stored there. The IRB protocol is there. Our SOPs are there. So that can be a sort of a useful area to know about. So let me pause there, see if there are questions about Teams and accessing information and Google Groups. All right. I'm going to come back and just summarize my last piece here, and then we can see if there are other questions. Yeah, that's it. So let me just open it up for any questions, any needs from a training perspective. Some of our training materials are from our very beginning, and some things have changed. So if people find things confusing, if you're feeling you need things, Shannon's your person. Just ask Shannon and we'll all work together to sort of fill in the holes. But what can I tell people that was not answered by this discussion? Or what else would people like to know about?
Yes, I have a question real quick. So yeah, you mentioned a BAA, I guess, business associate agreement. Is that necessary? Because we just got started up. We just got our IRB approval over here. I just want to make sure that's.
Yeah, so the steps are IRB approval triggers the invite to join the network, and your PIs can start to plug in, you guys can start to get trained. The BAA is necessary, especially for a REDCap site, because it's what gives it's what gives Utah permission to manage your research data, to manage your HIPAA protected data. And so I can't, there's two new sites that have joined, and they're in different states. And you guys have joined, and New Mexico has joined, and one of you has not signed a BAA yet because you're waiting for another agreement, and the other one has. So I think you have both of your agreements in place.
Okay.
I think, I'm not 100% sure. Shannon, I don't know. Yeah. And so once you have that, we can go and get you an affiliate account, and we enable you on REDCap. And so you can then go and do that. And Shannon, can you recall? I think we set up Michael on REDCap, didn't we? Yeah. Which means that there is a BAA in place. So, because we wouldn't have done that. I mean, we could make a mistake, but we wouldn't have done that unless there's a business associates agreement, because at the point you're entering data, you're transferring HIPAA data to Utah, and it needs to be protected under the auspices of that agreement. Okay, other questions?
I just wanted to add, if anyone doesn't have Teams or the Google Groups access, please let me know. You can email me or put it in the chat, and I can give access to you right now. So thanks.
All righty. Well, I hope this, for those of you that are new, I hope this gives you sort of context for this work that you're doing. It's tremendous work. It's been philanthropically funded from the beginning, and then we've had some great success with these grants. And we are entering a new phase where we're going to actually have participation fees for sites, and your PIs know that's coming. I assume that's someone commenting on something else and not what I just said, but maybe it's so gosh. But anyway, so we are entering a new phase, and we're making some pretty big investments in infrastructure. I hope to fill in some of those boxes where I am acting, and we will have some, like Shannon, we'll have more sort of professional resources to help the PIs, to help you guys make this sort of successful. And got lots of grants going on, lots of QI work. So it's great work, and I appreciate all that you put in to help us do this. So we're here. Don't hesitate. Don't be strangers. Don't hesitate to mail us. We're here to make you guys successful in getting the registry up and running and making the studies function smoothly. So thanks for your time.
Thank you.
Thanks, guys.
Thanks, Paul.
Thank you.
Thank you.
Bye all.
Bye-bye. Bye-bye.